and welcome, everyone. My name is Jack West. I'm a medical oncologist and the president and CEO of GRACE, the global resource for advancing cancer education, and I'm happy to be here with two great colleagues of mine from other parts of the country to talk about challenges of treating elderly and frail patients with lung cancer. With me today are Dr. Paul Hesketh, who is a medical oncologist and the director of thoracic oncology at the Lahey Clinic just outside of Boston in Burlington, Massachusetts, and also Dr. Karen Kelly from Kansas University Medical Center in Kansas City. She's a medical oncologist with an internationally recognized expertise in lung cancer. Here are the declared conflicts of interest for each of us in the program today. This activity is made possible through an educational grant from OSI Pharmaceuticals, who provided no input into its content. I'd like to turn to the very common situation of advanced lung cancer, non-small cell lung cancer in an elderly patient. This is an 81-year-old woman who had previously smoked a pack per day for 30 years and quit 31 years ago. She developed an increasing cough, productive of some clear sputum, and did not have any hemoptysis, did not cough up blood. She does have a notable past medical history of atrial fibrillation, spinal stenosis that is somewhat symptomatic and limits her ambulation, although she does get around okay, and she does have some valvular heart disease and a murmur, but her renal function is fine and really nothing that precludes treatment. She ended up having a chest x-ray to evaluate her cough. That showed a left upper lobe mass that was confirmed on a chest CT, and then had a PET CT that showed uptake of her 5-centimeter left upper lobe mass, multiple mediastinal nodes, left supraclavicular node, and a couple of rib lesions. These were all rather unambiguous in their PET uptake, and she ended up having an ultrasound-guided biopsy of a left supraclavicular node that showed an adenocarcinoma that was TTF1 positive and consistent with a lung primary. So we are in this situation of what to do for a patient who is over 80, has a performance status of 1. Paul, I think you have researched this question of how to manage a patient over 80. Would it be the same as your guidelines for someone 70 or younger, or would you make special concessions for that?
The reality is that when you look at the data that's out there, there is an extraordinary paucity of data in terms of outcomes in patients over age 80 with advanced non-small cell. In fact, it really consists of some retrospective reviews and a single phase 2 prospective trial. That's it, a very small study. Within the Southwest Oncology Group, we had conducted a trial that was focusing on basically two subsets of patients over age 70 and patients who had poor performance status, PS of 2, independent of age. And we did a couple of years ago sort of do a retrospective analysis from that study on a fairly large cohort of patients over age 80. We had a fair number of those, and combine that with a cohort from another study done by Dr. Rogerio Lillenbaum that had a similar entry criteria. So it was looking at a reasonably homogeneous population across two studies, and we took their subset of patients over age 80, took our subset of patients over age 80, and basically looked at the outcome versus the patients who were younger. And by younger in this situation, we're talking about basically 70 to 80, so somewhat younger. And what we found is that the patients who were over age 80 who had preserved performance status still had a respectable outcome in terms of their overall survival. It was on the order of approximately 7 months, which was shorter, the median survival in the younger cohort, but it was markedly better than the performance status 2 patients independent of age. The PS2 patients who were younger and the PS2 patients who were over age 80 did very, very poorly with a much shorter survival. So to me, that was somewhat encouraging that there might be some value for treatment there. I think that, again, one really has to individualize because we do not have any really good prospective data to give us recommendations. And so I think that I have to look at that individual, and there will be some patients who are 80, 81 who are remarkably preserved, and they're still out playing golf every day, have an excellent performance status, and they're really quite good shape. And I think that in that individual, I might consider even using a doublet where I might be using, say, a carboplatin combined with a second agent. I think more often than not, in the patients who are over age 80, I'm probably going to consider a single-agent chemotherapy regimen because we have good data that's evidence-based in the over 70 patients that those patients will benefit from single-agent chemo, and we don't even know in the patients over age 70 that they clearly benefit from doublet therapy. So more often than not, probably single-agent, although in selected instances when the patient's in very good shape, I would consider a doublet approach.
And Avastin is also FDA approved in this population technically, but there was a subset analysis of the ECOG experience that suggested that there was not any clear benefit in patients over 70, let alone 80. Would that really not be something that you would be inclined to pursue? Or would
I would not use Avastin in the over age 80 group, because I think the subgroup analysis from the ECOG study was very concerning, because not only did it show excess toxicity, but it was basically with no additional survival benefit compared to the control arm that didn't receive Avastin. Now, there was a subset analysis that was done of the other large phase 3 trial that was done in Europe, the so-called Frail trial, and their subset analysis, I believe, was over 65, which really wasn't an elderly group as far as I'm concerned, and they didn't show similar results to the ECOG analysis. But my word is really caution, I think, in an older subset about the use of Avastin, and certainly beyond age 80, since we even have very little data on chemotherapy alone. I think you would be on potentially very shaky grounds to use Avastin in that group of individuals.
Karen, what's your approach? Do you ever use doublets for patients over 80, or is it all over the range depending on the patient?
Well, I think certainly let me just echo what Paul said about Avastin. I do think that this subset analysis really speaks to the word of caution in elderly patients, and in particularly over the age of 80, and I do not use Avastin in this patient population. In regard to the use of single versus doublets, I think Paul, again, is right on in the fact that typically I would say that I tend to use more single agents, but there are those rare individuals to which I would consider using a doublet. And in particularly, I think with pemetrexed being such a user-friendly drug, I think that plus or minus carboplatin would be a very reasonable regimen to use. And if a patient could tolerate to try a doublet, I'm certainly willing to do that, knowing that, again, it's very simple to then drop out that platinum drug if you need to. So I think that I typically do use a single agent, but in those rare cases, I would consider using a doublet.
Now, Rogerio Lillenbaum did a study testing Tarceva versus doublet chemotherapy in a marginal performance status population that was largely elderly. In that study, Tarceva looked not nearly as favorable, but that was an unselected population. Would you be inclined to send off tumor tissue for an EGFR mutation in a patient like this who does have a significant smoking history but who quit more than 30 years ago, and potentially use the EGFR status to guide whether you would recommend a first-line EGFR inhibitor or standard chemo? Paul?
I think I've been doing it increasingly more and more, because I think that clearly this is not the ideal scenario in terms of the never smoker who's much more likely to have a mutation. But the reality is that this patient is very remote from her smoking, 30 years, and clearly that is an important factor, because the frequency of finding mutations is very dependent on total smoking exposure and time from cessation to diagnosis. So I think that there may be, in this particular patient, as high as a 10% or so chance that they may have the mutation. And that would have profound implications in terms of giving you a really very nice, viable option that would be reasonably well tolerated and probably have a better chance than any chemotherapy regimen of really giving her benefit. So I think increasingly I am doing those analyses, realizing it's going to be a minority of patients that have the positive test. But I think recognizing that, particularly in a patient that you're concerned about toxicity and you're concerned about their tolerance of standard chemotherapy, it gives you a very nice potential option if, in fact, they have the mutation present.
If she had said, I don't want chemotherapy and doesn't have an EGFR mutation, would you be inclined to give it as just an alternative, or would you mostly say that it's going to be impressive primarily for those with an EGFR mutation?
Well, again, clearly, as you know, some people get overly concerned about the mutations, and they assume that if there's no mutation, there's no benefit. And as we know, the trial that led to the approval of the agent was in pretty much an unselected population, and there was an overall survival benefit. So clearly, if the patient is not chemo appropriate or is absolutely denying any interest in chemotherapy, I think it is still a potential option that one can consider, even if they have the wild-type genotype and they don't have the actual mutation, because clearly some of those patients will benefit. They won't have the spectacular regression of disease, but they may achieve stabilization of disease, which still could have value.
Karen, what's your perspective on EGFR testing in this setting?
Yes, I would definitely do EGFR testing in this patient. I think that Paul hit the points, the fact that she is greater than 30 years from her smoking, that we do know that that could be a candidate. I think it's pretty hard to know who's really going to be those patients with mutations. Even the ones that we think, the never smokers, Asian, female adenocarcinoma, I can tell you that more so than not, I think actually I've not had one patient yet really be positive when I've tested them thinking that they will be positive. So even though we use those criteria, I really don't think that we should be limited by those criteria. So I think that adenocarcinomas really should be tested, whether they're male or female. So I definitely would test her. And I think that if she was mutation positive, that absolutely makes a huge difference in how I would treat her. And I would recommend that the patient receive Tarceva. I do think that if the patient did refuse chemotherapy, and I've had patients like this, as I'm sure you all have, and, you know, in our willingness to want to help these patients, I think that achieving stable disease and symptom control, I think we all know is very valuable in this patient population. So I, too, think that that is a very reasonable strategy for these patients.
She has bone lesions, and in general, we tend to offer and pursue a bisphosphonate therapy like Zometa to reduce the rate of further skeletal complications. Do you have an age concern with elderly patients receiving bisphosphonates because of the risk of renal toxicity, or do you really just look at the creatinine of a patient and the other potential contraindications and not concern yourself with the chronologic age?
Well, I typically do the latter. I look at their renal function and use that and other contraindications to make a decision about the bisphosphonates. So I don't have an age cutoff per se. I do think this patient, however, she just has a few tiny rib lesions, and sometimes I think I'm on the fence with treating this patient with bisphosphonates personally, because it seems like she just has really, really tiny lesions. And following her, I think that if she developed one more lesion, I then would consider starting that. But I'm not so sure I would start bisphosphonates for two tiny rib lesions.
So basically the magnitude of bone disease versus everything else happening is relevant.
Right. Again, it is another additional drug for these patients. And, you know, the one thing I've always learned from medical school is polypharmacy in the elderly is not a good thing. So,
Paul, what's your perspective?
Yeah, I don't have an age cutoff. I think that it really is defined by the renal function, because that's really the place that you can potentially get into trouble. So I think if the renal function is preserved to a level that we can give zoledronic acid, Zometa, either at full dose or adjusted based upon some moderate renal dysfunction, I would still use it. And obviously, in the absence of other contraindications, such as dental problems, they're undergoing dental work. They've had some problems in that regard. But I don't have an age cutoff, and I think that the bisphosphonates can be very useful adjuncts in patients with bony metastases. And I would basically go by the renal function as the primary criteria.
Well, I'd really like to thank you guys for your great thoughts and sharing your time. These are hard cases, but they're real-life situations. And the reality is that when we don't have data, it's probably most helpful to have the good judgment of thoughtful people who are working from the best principles we have. Thank you so much.